HRI told me I could moderate like 15 minutes ago. I mean, I'm exaggerating, but it was definitely a to be determined, right? So we are diverse needs and compassionate care. And we have some very powerful speakers who are going to talk about, well, they're going to talk about their dynamic work. It's compassionate care is the title, but they each are doing incredible work. And so I don't want to take up a lot of time yapping because they are the subject matter experts and they are far more interesting than anything I could come up with at this point. Okay, so everybody sent me a bio except for Jose? Blowing you up. So that means that you can do, we're gonna do like quick name, organization, if, and your focus, right? We'll just starting with you, baby.
Yes, good afternoon, everybody. I'm sorry I'm not speaking Spanish, but it's our last day of the conference, and this is my very first session after a very long time ago. I attend the harm reduction conference. So very glad to be here with you guys. I'm baby Virgarose Nurmaya, but you can call me with baby Aya. I came from Spin Foundation in Indonesia. Our focusing are for women and gender diverse people who are using drugs. Our base in Bogor, West Java, Indonesia. And actually, this is a very newborn of organization. We just registered on 2022. But what I want to share here with us today afternoon is our live experience become an initiative to our community. So that's all from me. Thank you.
Bueno, pues muy buenas tardes. Mi nombre es José Lozada. Soy enfermero en la organización Intercambios Puerto Rico. Llevo trabajando aproximadamente 8 años en reducción de daño y ahora mismo estamos trabajando en un enfoque que es trabajar lo que es salud mental, salud física con los participantes que van al programa de nosotros.
Hi, everyone. Thank you for being here. I'm Tatyana Sleiman. I'm the executive director of SCOON, which is a harm reduction center based in Beirut, Lebanon. So I'm also based in Beirut. I'm coming from there. And basically what we do is we provide services for people who use drugs, and we provide also in-depth mental health treatment support for people with substance use disorders. And we work on drug policy reform also, because I come from a country that very heavily criminalizes people who use drugs. And today I will be presenting a bit about the crisis situation that we've been through over the last 5 years, and then how we've used this moment to be able to integrate harm reduction into public healthcare services in Lebanon. And happy to be here, and thank you all for being here. Last day, last session. Thank you. Thanks.
Hi, I'm McCutcheon. I'm a nurse. I'm an advanced nurse practitioner, and I work for an organisation called Cranston.
You want me to go that way?
I work within a drug service in a place called Sandwell, which is in the middle of England. It's an area of quite high deprivation. And I'm talking today about a specific model of outreach that we've developed there over the last 18 months.
I just need to give them.
And thank you.
Thank you.
To HRI for inviting me.
Happy to have you. Just FYI, my name is Tracie Gardner. I'm from the US, and I'm the executive director of a new organization called the National Black Harm Reduction Network, which is focused on the disproportionate mortality from overdose in Black communities around the country. So, again, just very eager to hear more from each panelist. And I'm told I need to follow the agenda. So the first person to talk will be Tatyana. Do you need the clicker? Yep, okay.
Okay. So hi again. So like I said, I'm here to present the work that we've been doing in Lebanon to integrate harm reduction services for people who use drugs into the public healthcare system. So I'm just going to start with giving a bit of an overview on the context in Lebanon and the background, and basically how we were able to use the momentum of different things happening in parallel to be able to spark this initiative of integrating harm reduction into public healthcare. So in Lebanon, historically, the public healthcare system has been very fragile. Our healthcare system is extremely privatized, extremely, it's a healthcare system made for the wealthy, for people who have money. And it's also a public healthcare system that excludes people who use drugs and other marginalized communities. So for a very long time, the services for people who use drugs have been housed within a selection of private NGOs, organizations, or within like mental health care facilities that would cost a fortune for people to be able to access them. And SCOON, as an organization that works in harm reduction for 25 years almost, our mandate has been from day one integrating the needs of people who use drugs into public healthcare and into public healthcare strategies. And we had been trying to do this for a very long time, but it actually, unfortunately, took a series of very heavy crises hitting the country one after the next since 2019. So, I mean, we've had crises since forever, but in 2019, for those of you who are not a bit familiar with the context, I will give you like a very, very brief overview. There was a massive uprising in the country against the political system and a very corrupt political system. And then we went into a very heavy economic crash in the country with a devaluation that reached over 250% of our currency. At the same time, in 2020, we had the massive Beirut port explosion, which most of you have heard about. Of course, this was happening in parallel to COVID. And then finally, last year, we ended up with a war that most of you have heard of, an Israeli attack on Lebanon that lasted for 3 months. So throughout this whole period of crises, one of the things that happened in Lebanon is that a lot of donors started investing, humanitarian donors started investing in the country. And because people in Lebanon lost almost everything in terms of, their money, their assets, etc., there was a shift from the private medicalized response to investing more in public healthcare. So it came as a necessity, but eventually it turned into something good because it actually meant that there were more investments in public healthcare. There was more capacity building for public healthcare workers, and it shifted also the access to public healthcare. So I will show you in the next slide. Even though public healthcare facilities existed, very few people used to access them, and very few Lebanese people used to access them. So up until 2018, these facilities were mostly accessed either by migrant workers or refugees because they were low quality services, unfortunately, and low cost services. So in parallel to all of this, substance use is criminalized in Lebanon up until today. So the law in Lebanon criminalizes people who use drugs, but the law also gives the alternative to prosecution if you seek treatment. So it's kind of coercion to treatment, but at the same time, it's the only loophole that we have right now in our law to make sure that people are diverted from incarceration. So we do have this in our law, and our law also stipulates that the state or the government should provide treatment services and support services for people who use drugs. However, these services never exist. So you get arrested, you go to an entity within the Ministry of Justice called the Drug Addiction Committee, and you say, okay, I have a drug problem, I want to seek support. If there's not a private NGO that's able to welcome you, there's no public healthcare facility that can provide this support. So it's really, you're caught in a cycle. And a lot of people would end up in jail just by default because they don't have any other option. So the initiative of integrating substance use response into public healthcare came from this, different things happening in parallel that kind of somehow created a momentum for us to push for the state to actually take ownership of the law that they have, which stipulates that they need to provide services for people who use drugs. So this is actually from a report by the UNHCR and the WHO, and just it shows you, so it starts in 2018, which is pre-crisis, And then it shows you, as we go more in depth into the crisis, how more and more people started accessing services in primary healthcare centers, which is, it's not a governmental hospital, but these are public facilities that provide different types of basic services, health services for people. And you will see how, so in green, it's the non-Lebanese that used to access the services. And then you will see how the further we go in depth into the crisis, so more people in general will start accessing services in primary healthcare centers. I will call that PHCCs moving forward, just to make it easier. So that's public primary healthcare center. And then you will see how we go, the further we go into the crisis, there's more people coming into the services, but particularly more Lebanese people accessing services in these facilities. So what was the objective from going after the integration of harm reduction and substance use services into public health care? So obviously the idea was to be able to increase access and also to decentralize the access, because those few NGOs that I spoke of, which Schoon was one of them, that provided these services, most of us are centralized within Beirut, which is the capital. But this also means that for a lot of people who are outside of the capital, who are living in the north, in the south, in the Bekaa, to be able to access it, so you either don't know about these services at all, or if you want to access these services, you have to commute for 2-3 hours. And a lot of people would end up deprived of these services because of that. And because the network of primary healthcare centers is literally all over Lebanon, we have over 200 primary healthcare centers, going after these facilities and starting to integrate these services in those facilities made sense. At the same time, opiate agonist treatment in Lebanon is legalized and available. However, there is a very intense protocol of service provision that people have to go through to be able to access the medication. So you have to have psychiatrists that are accredited by the ministry to prescribe this medication. And then to access your prescription, you have to be seeing a therapist, conduct urine tests, and see a psychiatrist. None of these services are afforded by the state. So once again, we are in this loophole where we have a state that's enforcing a specific protocol but doing absolutely nothing to provide that service provision protocol for people to access these services. So one of our primary objectives when integrating these services was to integrate the OAT service. So to make sure that there were different primary healthcare centers across the country that had in-house a psychiatrist that's accredited to prescribe OAT and a team that is actually trained also about the opiate agonist treatment, what it is, because also, even if you are a psychiatrist that's going to go, to university and study, or a therapist, you will get a very short curriculum about drug use. Although, after the Civil War, we had like a heroin epidemic in the country, and still this was never prioritized, even in terms of the capacities of the healthcare practitioners. So the idea was this. The main objectives was to increase and decentralize the access to a various range of harm reduction services, but primarily the OAT. At the same time, it was a medium to reduce the stigma towards people who use drugs, because once you are recognizing this as a basic healthcare need, like any other healthcare need, obviously when you're present in these spaces, you're also changing the culture of the community that is living around these spaces to recognize substance use as a healthcare issue, as a social issue, rather than a criminal issue. And then, particularly going for public sector and public healthcare sector, the idea was also around sustainability. So we all know that NGOs will exist for a certain period of time. At any point in time, you lose your funding, you lose your mandate, you lose whatever. The board decides to change their mind and shut down an organization. People will lose access to services. So for us, the only reasonable way to make sure that these services are sustained is if they're institutionalized into the public healthcare setting. So from that, in the beginning of the economic crisis, we had an opportunity, which was basically the French Development Agency, which is the main French governmental donor to Lebanon, so the aid provider from the French government to Lebanon, who decided to invest in a project that's focused on mental health care in Lebanon. So they were working with Médecins du Monde, which is a French agency that has a mission in Lebanon. And through the ministerial National Mental Health Program, which is a ministerial program, we as Schoon were put in contact with Médecins du Monde to see if there would be a way for us, under the umbrella of mental health care and mental health response, to integrate substance use services into public health care. And this is how this started. It started with a project, basically, that was funded by the AFD, where we located 3 different PHCCs in 3 different regions in Lebanon, where you will see the dots, so in Beirut, in the north, and the Bekaa. And the selection obviously came from, first of all, the willingness of the primary healthcare centers to house substance use services, but also the likelihood of these primary healthcare centers to sustain these services after we're gone. And also by budget. This is why we ended up with 3 PHCCs and not more. So the idea was to go into these primary healthcare centers, launch the service, so train the teams, create protocols, create operating procedures, and then doing community outreach around the centers so that we can start introducing people about the different services that were being provided, and then deliver the different types of services. And of course, this meant that we had to develop training programs, we had to do a lot of community outreach within the community. First of all, to explain, what are mental health issues? What is substance use? How do you access these services? What are these types of services? But also there was a lot of work to be done, particularly on the substance use and harm reduction component with the PHCCs, because the healthcare workers had no idea. So it's literally, we had to start from scratch, creating whole curriculum for them to be able to integrate these services and then accompany them for a while. So supervision, shadowing, clinical meetings, etc. And the first phase of this project, we were able to house the service in Beirut and in Baalbek. And then in a second phase of this project, we were able to sustain these 2 services and then move up to north. So currently these services are housed still in those 3. The project is over, but the services continue, and they have been in the north and in the Bekaa fully integrated within the PHCC. So we're not there anymore. We just provide some technical support every now and then, but the primary healthcare center is fully managing and operating these services. In Beirut, we still had to, it's more of a semi-integrated model just because the caseload was too high and the primary healthcare center did not have the resources to be able to fully integrate these services. So it did succeed at different ranges, because it depends on resources, it depends on caseload, it depends on a lot of things. But the idea is it's been institutionalized, so it's also become part of the national strategy, national health strategy and national mental health strategy, to be able to have not just substance use response services, but harm reduction services. So it was also essential for us that it's not just drug response, it's drug response that is founded and based on harm reduction to ensure also that the philosophy of harm reduction is integrated. So it's not a top-down approach, it's not, abstinence-based, it's not, the OAT program is recognized and institutionalized. So it was a way for us to sustain these services in a fragile context. What we've been able also to see, because we've been working on these services in a backdrop of crisis after crisis, is that these services actually, or this type of integration is actually very agile and very adaptable, especially because it's an outpatient model, so people don't have to come and stay, it's low cost, it's not a lot of resources invested, and it's easy for people to access. And it also enables us to reach a higher number of people because of the cost efficiency. So just to give like a very quick overview of what we've been able to do through these services, so over 1,500 people reaching different various types of harm reduction services, including 350 people, new people that were initiated on the OAT program and who are still receiving the OAT program. When I say 350 people, this is on top of 1,200 people that are already in the OAT program, but that were solely housed, that were solely localized in Beirut. So now we have the OAT program also present in the Bekaa, in the north, through this initiative. We have over 120 new health workers trained on harm reduction and on substance use response. And where we're talking about healthcare workers, we're talking about general practitioners, nurses, psychologists, caseworkers, psychiatrists. So it's a various range of frontliners that work in different primary healthcare centers that are able to respond somehow to people with substance use disorders, or people who are using drugs but need some form of support. And then obviously, because of this ongoing work where we had to engage, the Ministry of Health, the different programs by the Ministry of Health through every single step of implementation. So it also really strengthened the collaboration between CSOs working on harm reduction and drug response and the Ministry of Health. So now we are much more involved and engaged in any new strategy that they're trying to develop, any new training related to substance use that they're trying to implement. They are listening to us, and obviously, we are from the community and we work with people from the community, so we are able to bring also the voices and the needs of the community into those new strategies and those new curricula. In terms of lessons learned so far, so obviously it hasn't been a very linear journey. There's been a lot of challenges while we were implementing, a lot of setbacks because of what's been happening in the backdrop in terms of crises, but also because of shortages in resources every now and then. Changes, let's say, in the management of a primary healthcare center where we had to start the process all over again so that they are continued to be convinced to have these services. At the same time, one of the biggest lessons learned that for us as people who have been working in harm reduction and drug response was the engagement of what we call, going beyond the usual suspects when it comes to resource mobilization. So up until the period where we started these initiatives, there were a list of like 1, 2, 3 donors that we would always go through to, them, the Global Fund, a few others. Those were, the drug harm reduction donors. And through this period of humanitarian response, we have actually been able to engage a lot of governmental donors who usually would not have addiction or substance use in their mandate when it came to any form of aid that they gave. But because we've been able to integrate this into mental health and to health response, we've been able to engage a whole new network of donors and of UN agencies that also were not paying enough attention to the issue of substance use, like the UNHCR, for instance. Another major lesson learned was being able to use the crisis as a catalyst also for system reform, which is sometimes when you're in the middle of a crisis, it's very difficult to see any positive outcome, but it's also a moment of disruption. And in a moment of disruption, it's an opportunity to also build differently. And I believe this is probably one of our biggest lessons learned from 2019 up until now. On the not so much, I wouldn't say on the downside, but maybe like a wake-up call that we've had also, which is things don't change overnight. So even if we have been able to go down this route of integrating services into public healthcare, we're not yet in a place where we can say that these services can take the place of the NGOs or the small safe spaces that exist, because public healthcare is not accessible to everyone in Lebanon. So if you belong to a specific community, if you're queer, if you're a refugee, if you're a woman survivor of GBV, there's different communities that you can belong to that still hinder your access to a public healthcare facility in Lebanon. So it's important, as we continue this movement, to continue to protect the safe spaces that exist and understand that these cannot replace those, at least not in the midterm period. And so from that, we have like a series of recommendations that we follow up with the different agencies and stakeholders that are involved. Primarily the issue of policy reform. We know that at the basis of lack of investment in public healthcare response for people who use drugs, at the basis of the stigma towards people who use drugs is criminalization. And as such, an essential thing, an essential mission that we continue to work on in Lebanon is trying to reform the law and to push for the decriminalization of people who use drugs and to further integrate harm reduction in the national public healthcare strategies. Also expanding the capacity building of healthcare workers, whether it's university curricula or the postgraduate trainings, etc. So to have more opportunities for healthcare workers, social workers, people who are public health graduates, to be able to have a better understanding of drugs, harm reduction, and how to operate that in practice. Funding, of course, remains an issue. So integrating some funding from harm reduction into ministerial budgets is actually our next focus. So it's in the strategy, it's in practice, it's in the public healthcare systems. Our next, hopefully, goal is to have the ministry allocate a specific budget within the ministerial budget specifically for harm reduction services, and to continue to replicate and scale up this model across different PHCCs in different governorates in Lebanon. I'm done? I have time? Okay, wrap it up. It's my last slide. So, the way forward is to consolidate this pilot. And when I say consolidation, it's not just sustain it, but also do the evaluation needed every now and then to be able to generate also some evidence on its efficiency and its efficacy so that we can continue to keep it going, expand it into different regions in Lebanon and hopefully also into different regions in the MENA region, because through this model we are creating training modules, we are creating operating procedures, and it's all done in Arabic, which is not something that we usually have. So also be able to expand it in the region. Continue to institutionalize harm reduction as an evidence-based response within the national health strategies. Continue to ensure that there are alternative spaces for people who are not able to access PHTCs, secure the sustainable funding, and eventually position harm reduction as a human rights obligation for the Lebanese state. And on that note, I will end. Thank you very much.
Next is Sue. Yes. Okay, Sue, so you saw me leaning back. I give you the eyeball. Keep an eye on me.
Yeah. Oh, too many. Okay, so I'm here to talk about a specific model of outreach that we've been piloting in Sandwell in England over the last 18 months. We've called it the Dynamic Evolving Model of Outreach, which is a bit of a mouthful, so it's much easier to say demo. But just to say something to start with about drug service delivery in England, it's typically delivered from buildings. So there'll be often a core service in an area, a building where most of the services are provided from. And then in some places, there will be other venues in the community where some services are also provided. They might be operated from doctor surgeries or community centres. So it's more local for people to get to. Some drug services will also provide some level of street outreach, obviously aimed at engaging with homeless individuals. But that also often has limitations as well. I mean, I'm a great believer in street outreach, and I've done street outreach for 20 odd years. But often in the UK anyway, if, for example, somebody is met on the street and they want to get onto OST, the expectation is that they will travel into a building for that. So that is a gap in a sense. So that is kind of the starting point for where we started to think about providing a different approach, really, because we really wanted to try to reach people who the traditional model that was offered just doesn't work for those individuals. I think we all know that there are people in our communities who don't come into buildings for one reason or another, and they don't use services in that way. And so demo is, the thinking behind demo was all about trying to engage with that group. So it was about really trying to work with people who are homeless, people who've got the highest level of care needs, often very complex health needs, and try to reach out to people who have had no previous contact with services or no current contact with services. And, you know, this is a group of people that certainly I've heard talked about as and described as non-engagers, poor engagers, people who are not ready for treatment, people who are poorly motivated. And, you know, those phrases, you know, are very blaming, aren't they? So, you know, demo is about turning that round really and saying that's our responsibility. It's the services who've actually failed, really, to achieve any kind of contact with those individuals. And that is our problem and not theirs. You know, we're the people who are being paid to provide services and try to reach all those groups within our communities. And if we know that there are groups who are not accessing services, then that's our problem and our responsibility to do something about. So we set up demo, and it was funded via the organisation I work for, the Cranston. They have an internal innovation fund, and they funded it for an 18-month pilot project, which has just come to a conclusion, for 3 days a week, with myself as a nurse and an outreach worker, drug outreach worker, And it's been research evaluated by Queen's University in Belfast, and the research was led by Gillian Shorter. And it's a street-based project, and it's all about meeting people where they're at. So yes, geographically, in outdoor spaces where they're actually using drugs, in places where they're begging, and places where they're sleeping. But importantly, it's also about meeting them where they're at psychologically. So again, in the UK, I would say that, if you're an opiate user and you're coming, if you're coming to a drug service, then the pathway that is generally sort of on the table for you is about getting onto a script, onto a prescription. And if that's not what you want, then in many ways, you won't be going along to that service because that's the offer generally that's on the table. So this is all about letting go of our expectations really as drug service providers and opening up to working with people, obviously wherever they're at in their sort of journey, if you like, of using substances. And letting go of the word treatment. Certainly in the UK, we talk about drug treatment services, and stopping using that word really, and talking about care and support in whatever form that means. And I'll say a bit more about that in a minute. And why is this needed? Well, I find it interesting. Certainly, again in the UK, in the last 10 years or so, we talk more and more and more about trauma-informed care. And yet we rarely talk about trauma-informed access to our services. And that for me is really important, because there are lots of reasons why people struggle to come to buildings and what buildings represent. And whether we like it or not, we're part of a system, aren't we? That often, the people we see, certainly within this group, many of those individuals have undergone a lot of trauma in their lives. And the system can sometimes, that structural trauma, that's part of it. And coming along to buildings can be very difficult for people. So this came out in the research evaluation. The researcher interviewed quite a number of people on the street, and they talked about not wanting to come to buildings, and they talked about finding it difficult to sit in waiting rooms and that kind of thing. They also talked about these other things, the lack of money to get transport into services. And they talked about being exhausted, not having slept sometimes for several days, lack of food, not having eaten for several days, and all of these things, physical health problems leading to people really struggling to make that journey in and make that kind of, the effort that took was just too much to get into buildings. And the day-to-day challenges of just surviving and getting through the day, waking up in opiate withdrawal. The first thing they've got to do is make money, get out on the street and raise money and then score and use, and then they're back around that circle. And where in the day are they going to find the time to spend 4 hours, 5 hours travelling along to a service and sitting and waiting to be seen, etc. So what we were offering, as all outreach street work is about the engagement, isn't it? The most important thing is those building of relationships with people. But as I said at the beginning, one big gap in street outreach, certainly in England, seems to be this access to OST, because we have people out there, peers and drug workers out there on the street working, but actually, where are the prescribers getting out there and getting out on the street? So as a prescriber, probably about 3 months into the project, we decided, right, okay, why don't we do this and just get out there and prescribe on the street? So that's what we've been doing. And it's so simple. And I don't really understand why everybody else doesn't do it as well. Because it's just the same, the process is exactly the same as I would do sitting in an office to doing an assessment on the street with somebody, exactly the same. We have to be a bit creative in terms of the sort of how we titrate people, and people often fall off script of their prescription. They struggle sometimes to get to pharmacies just like they do to get anywhere, really. And so we have to rapidly restart people. So people will let us know when they've come off script, and we'll be out there. We aim to get out there the same day to get them restarted. We do a lot of health interventions, and I'll say a bit more about that in a minute or two. But also all these other things, the harm reduction interventions. We give out equipment, foil, naloxone. And in the research evaluation, one of the things that really came out of that was that how much they preferred in many ways to, get that equipment from ourselves. In England, some pharmacies within the community will be giving out equipment. But what they talked about was they were basically rationed in some of the pharmacies in getting equipment. And so they found it easier, in a sense, to get sort of equipment from ourselves because they would get the appropriate amounts of equipment that they needed. And also additional items, because there were some items that we provided, like antimicrobial hand wipes, so they could, conduct good hand hygiene before preparing and using their drugs, and things like sterile water, which the pharmacies didn't provide. And all these things at the bottom, I mean, they're small things, aren't they? Drinks, snacks, clothing, toiletries, bedding, etc. But again, in the research evaluation, it really shone through that how much people valued these things. People talked about how much it meant to them to get a pair of socks when they'd been wearing a pair of socks for 3 weeks. A woman talked about how much it had meant to her to be given a hairbrush because her hair was all matted together. And I mean, somebody talked about how really their only time that they ever had food was when we gave them food. So, these things are so important. And in terms of the health challenges, I mean, the people that we see, they generally have very complex, unaddressed health needs. And just to give you a couple of examples, we have a man in his 50s that we've worked with since the beginning of the project. And, it came to light that he hadn't been registered with a doctor for 20 years. So you can kind of imagine the amount of health issues that's uncovered as we've started to work with this man, Somebody else, we took along to see a doctor, and the doctor wanted blood tests completed on this guy. And that was another thing really that came out, that several of the people needed blood tests doing, and they don't want to go to the hospital and have their bloods done because they've got quite difficult vein access. And so they'd said to me, I'd much rather you do the bloods. So we decided to implement that within the practice, and for me to start doing bloods on people. And we took this one guy to the doctors, and the doctor requested bloods, and I did his bloods. And when we went back, the doctor was staggered because she said to us, I can't believe we've got blood results on this guy. He hasn't had bloods for 16 years, So, so much, neglect of health, and so many things that, have needed to be addressed for individuals. So we're dealing with acute and chronic conditions on a day-to-day basis. The chronic conditions that we all have here, a myriad of things, diabetes, people with asthma, people with epilepsy, etc., that just haven't had medication. We had another man who was asthmatic, and again, when we took him to the doctors to get inhalers, it came to light he hadn't had his inhalers for 14 years. So, such a lot of long time for problems to be affecting people. And then all the acute problems as well. And the people that we're generally dealing with are injectors. They are heroin and crack users. Often they're injecting both together as snowballs. And so many of the acute conditions we see are infection related to their injecting. From abscesses that they will incise themselves because obviously they're reluctant to go to hospital, through to much more serious conditions, things like endocarditis, infections of the heart, infections of the joints, infections in their bone, to sepsis. And we've had quite a number of people with sepsis over the course of the project, including, I think, towards the end of February, we had 3 people with sepsis in one evening, and all went to hospital. One ended up in intensive care. They've all survived, thank God. And, these are people who weren't engaged with drug services. We've had some people with those really serious conditions who've never been in treatment before, never been involved with drug services at all. I am able to prescribe some medications for people in emergencies, like antibiotics, and that's probably the most common thing that I prescribe, but that also is really useful to do. And we do actually accompany people to health appointments, to see doctors, to hospital appointments, but to all these other things as well, like dentistry, opticians, women to cervical screening. I'm aware of the time. So just very briefly, just a few stats. Over the course of 18 months, we saw 197 different individuals. 110 gave their names, and it's absolutely fine for people not to, give their names at all. And you can see the breakdown in terms of gender and age. The interviewer conducted 42 interviews over the course of the time, and without exception, all of the responses were universally positive about the project. And the only negative was that people who were interviewed, they wanted more of the same. They wanted more workers out there doing exactly the same thing, and they wanted us to be doing more hours, more days, because we're a 3-day-a-week service. And some people very clearly said they wanted us to be 7 days out there, and they wanted to see us every day for 7 days a week. Now, over the course of the project, some people we only saw once. Some people will just come up and just want a pair of socks and some porridge, something to eat, and that's fine. And other people we will see, we work with very intensively, we will see 3 days a week. So it's a big range. But just to give you one example, one individual we had, we've still got, he had more than 90 health-related interventions in 18 months. And that's not including harm reduction interventions, social care interventions, getting identification for him, documents, and, taking him to criminal justice appointments and, opening bank accounts with him and all these sort of things, but 90 health-related interventions. So how can we ever talk about this group of people as people who are not interested in treatment or support? This is a group who absolutely wants support, but it needs to be provided to them in a way that they find accessible and compassionate. And that's me. Thank you.
Bueno, pues buenas tardes nuevamente. Mi nombre es José Lozada. Vengo de Intercambios Puerto Rico. Primero que todo quiero agradecer, ¿verdad?, aparte de las personas que me ayudaron, trabajaron conmigo en colaboración en este proyecto, que no están aquí presentes, que es la doctora Elisa Pujols, el doctor Luis Román, y aquí presente tengo a Brian Alvarado, que también es compañero de nosotros de intercambio y apoyó en este proyecto. Venimos a hablarle, ¿verdad?, un poquito de lo que es Intercambios Puerto Rico. Vamos a darle datos de lo que sucede en Puerto Rico. Vamos a hablar del proyecto que tenemos en Methadone bajo la iniciativa de la móvil, el proyecto de la móvil de nosotros, y los datos que hemos recopilado en el poquito tiempo que lo hemos trabajado en el proyecto. Pues Intercambios Puerto Rico es una organización que se funda en el 2009, enfocada en lo que es el intercambio de jeringuilla y la reducción de daño. En los pasados años, ya como los últimos 4 años, Intercambio ha tenido un crecimiento en el cual ahora se está trabajando lo que es más salud mental y salud física, integrando la reducción de daño en el mismo. Estamos ubicados en el área noreste, que es el pueblo de Fajardo, y esos son los municipios que trabajamos en toda la isla, dando servicios no necesariamente de reducción de daños en todos, pero sí hay un servicio que es de vivienda, que lo trabaja Brian, él es el coordinador del proyecto, y esos servicios pues se dan allá. Y en la clínica de Fajardo, pues que tenemos la clínica de Methadone. Puerto Rico tiene una crisis que, ¿verdad?, como nosotros como proveedores de servicios, en la isla tenemos un problema a la hora de los servicios que nosotros no podemos darle a nuestros participantes, el poder referirlos a otro lugar, porque tenemos una escasez de médicos especialistas, porque se nos han ido del país, por la razón de que no hay financiamiento ¿verdad?, a la hora de ellos dar su tratamiento. También tenemos un problema que es que somos una colonia de los Estados Unidos y nos asignan fondos mucho menores a lo que le pueden asignar a cualquier otro estado, ya gracias a nuestro estatus colonial. Y también que la tasa de pobreza en nuestra isla es de un 41%, que si la comparamos con el estado más pobre de los Estados Unidos, que vendría siendo el estado de Mississippi, ellos tienen un 19%, que vendríamos duplicando lo que es el estatus de pobreza de la isla. Y también teniendo en consideración que el ingreso anual de una familia, ya sea componiéndose de 2 personas que vivan en un mismo hogar, es de aproximadamente $24,000 al año, que es bien poco para lo costoso que es vivir en la isla. Tenemos unas barreras los participantes de nosotros presentan unas barreras como lo es la transportación, porque aunque la isla sea un 100 por 35, no es muy grande, pero sí a nivel geográfico es bien difícil llevar a diferentes espacios de la isla. Tenemos un problema de falta de vivienda y más ahora con la gentrificación que están llegando muchas personas de afuera a comprar en nuestros espacios, nos están despachando a la gente local que vive allí, nos los están sacando y tenemos muchas personas sin vivienda. Tenemos poco acceso a tratamientos de salud. Hay muchos tratamientos de salud, muchos lugares donde dan servicios de salud donde no aceptan a las personas si tienen un uso problemático de sustancias o si están en tratamiento del uso de problemático de sustancias. Tenemos un problema con la documentación de las personas. Al ser una isla que es colonia de los Estados Unidos, tenemos muchas personas también que nacieron en Estados Unidos, pero son puertorriqueños. Pero a la hora de conseguir, por ejemplo, un certificado de nacimiento, que la persona haya nacido en los Estados Unidos, se nos complica mucho el poder conseguir ese documento. La población usuaria de drogas inyectables en Puerto Rico, según el COC, es de más de un 50%. Y estas personas experimentan, ¿verdad?, falta de vivienda o peligro de perder la vivienda. Y a su vez, ese 53% presenta condiciones de salud crónicas que no son atendidas. El proyecto de la móvil y metadona empezó el 2 de noviembre del 2023 y empezamos a implementar los servicios de reducción de daño dentro de una clínica de metadona, que para nosotros esto es algo súper innovador en la isla, porque metadona, quien da los servicios de metadona en la isla, es el Estado, y el Estado tiende a ser bastante punitivo con las personas que consumen sustancias. Pero el poder lograr que entremos con los servicios de reducción de daño, haciéndole entender a las personas que trabajan en metadona que lo que ellos están dando es un servicio para tratar su problemática de uso de sustancias a opioides y que los participantes siguen teniendo otro consumo de sustancias, que es el que nosotros podemos atender, pues hemos logrado un buen servicio, ¿verdad? Y poder lograr estabilización de muchos de nuestros participantes. Trabajamos desde los principios de la reducción de daño, como el humanismo, el pragmatismo, individualismo, autonomía, incrementalismo y la reducción de cuentas y sin terminación de servicio. Estamos logrando que las personas que están sin hogar, que no necesariamente tengan las mejores condiciones de salud cuando nosotros trabajamos con ellos, logramos que estas personas puedan lograr ser un poco más independientes en su vida, que puedan lograr hacer sus gestiones por su cuenta, por ellos mismos, no necesariamente que tengan que necesitar la asistencia de algún manejador de casos, un enfermero o algo para poder hacer algo que ellos pueden, como poder conseguir sus documentos, entre otras cosas. Trabajamos con los determinantes sociales, brindamos psicoeducación sobre inyección segura, sobredosis, acceso a tratamiento, entre otras cosas, como el sexo seguro, y brindamos apoyo en el manejo de casos y servicios psicológicos y servicios médicos. Con los servicios médicos tratamos de trabajar con las personas llevándole el servicio médico a donde se necesita, no necesariamente que ellos lleguen donde nosotros. Si, por ejemplo, ellos están en un shooting gallery donde se consume sustancias, pues nosotros tratamos de llegar ahí y dar el servicio de nosotros ahí, ya sea los servicios de manejo de casos, los servicios de limpieza de úlceras, de heridas. Contamos con médicos, que el médico también evalúa, aunque tenemos un problema con la cuestión de los médicos, porque a nuestras aseguradoras pertenecer al gobierno, en ocasiones el médico de nosotros está de manos atadas al no poder darle recetas a los participantes, porque necesitarían una contrafirma de su médico primario o médico de cabecera, el cual en muchas ocasiones nuestros participantes no saben ni quién es. El acceso a la clínica de metadona nos ha permitido, ¿verdad?, tener un contacto más directo con la comunidad, porque también hemos llegado a personas que no necesariamente consumen los opioides de manera inyectable y no necesariamente son personas que están en la calle. Tenemos muchos participantes ahora que son personas que tienen vivienda y que no necesariamente en las rutas de nosotros, al llegar a la calle, los podamos encontrar a ellos allí. Y eso nos ha acercado, ¿verdad?, a personas nuevas, participantes nuevos que tienen otras dificultades y podemos darles nuestros servicios también. Los servicios directos a la población de la clínica de Methadone se le dan servicios de salud física, ahí se trabaja, ¿verdad?, con el médico. Si tenemos personas hipertensas, diabetes, entre otras condiciones, pues se puede trabajar directamente con nuestro médico. El área de heridas, de curaciones de heridas por abscesos, ya sea por el consumo o por cualquier otra situación, se la podemos también trabajar. El acceso a tratamiento de sustancias, porque tenemos la clínica de Methadone que nos está ayudando con eso. El manejo de casos para poder conseguir sus documentos, en la estabilización de condiciones crónicas de salud, que ahí nosotros tenemos, ¿verdad?, lo que sería nuestro caso estrella, que tenemos un participante, el cual estaba en riesgo de amputación de ambos brazos, y la primera opción de un médico fue amputación. Nosotros pudimos manejar la situación y lograr que se buscara una segunda opción, pero volvemos. Nuestros participantes, aunque sea a la isla, un 100 por 35, el decir un viaje de 3 horas, quizás para muchos aquí no sea un viaje largo, pero para nosotros en la isla, geográficamente es un viaje eterno. So, es bien difícil, pero se consiguió. Y voy a darle un poquito para atrás para que vean el mapa de la isla. Tiene un pointer. Este es el pueblo de Nahuabo, donde nuestro participante vive. El servicio que le conseguimos se mueve a esta parte de la isla que sería Mayagüez. Aquí fue la segunda opción que encontramos. No existe una carretera que cruce de aquí a acá, derecha. Aquí la única opción que nuestro participante tiene viajar es por el área norte de la isla o por el área sur. Por ambos lados es lejísimo para nosotros. O sea, estamos hablando de viajes de 3 horas y media, que es un viaje súper largo. Pero en esa segunda opción logramos, ¿verdad?, conseguir una médico mucho más empática con la población de consumidores de sustancias, el cual nos dejó saber que no hay amputación de esos brazos. Y eso para nosotros, pues, es un logro, porque tenemos una persona que ya estaba un poco decaída por la noticia de que te tienen que amputar los brazos. A nadie le gustaría aquí que le cortaran los brazos. So, por esa parte, pues nosotros sentimos que logramos ese logro y nos sentimos contentos por eso. En los datos del proyecto, tuvimos del 2 de noviembre al 27 de marzo del 2025 457 visitas a la clínica móvil dentro de la instalación de Methadone, tomando en consideración que esta visita a la clínica de Methadone nosotros lo hacemos los jueves y estamos aproximadamente entre 1 hora a 2 horas solamente los jueves. De esas 457 personas, 79 participantes eran sin repetir. Eran 3 féminas y 76 masculinos. Se dieron 517 servicios. De esos 517 servicios, 428 fueron de psicoeducación, 29 en servicios de enfermería, que esto es servicios básicos como signos vitales y orientación sobre consumo de sustancias, 21 limpieza de úlceras o abscesos, 21 manejo de casos. Se repartieron 483 materiales, que entre ellos, pues, los materiales de reducción de daño como jeringuillas nuevas, condones, pipas de crack, todo eso. Se reparten vitaminas. Las vitaminas las repartimos cuando las recibimos, porque, ¿verdad?, trabajamos también por lo que son donaciones y no todo el tiempo tenemos donaciones para poder darle vitaminas a nuestros participantes, que en muchas ocasiones tienen déficit de las mismas. Repartimos 22 materiales de limpiezas de úlcera, porque, ¿verdad?, como les mencionamos, los vemos una sola vez a la semana y se les reparte material para que ellos puedan hacer, y de educación, para que puedan hacer sus limpiezas en su espacio o en su hogar. Y 29 bultos, ya digo, 12 bultos de necesidad de cuidado, que sería ya lo que es cuidado personal, higiene, limpieza, jabón, champú y esas cositas. Estas son las referencias. Y para terminar, ya que estamos aquí, quisiera también, ¿verdad?, de manera personal, ya que ya no pertenece a nuestro equipo directamente, pero sigue siendo nuestra compañera de lucha y participó en el principio de este proyecto, y es Gabriela Zavala. Así que, un aplauso. Eso sería todo. Buenas tardes.
And last but definitely not least, thank you, Jose. Baby.
Okay. Last but not least. Yeah, thank you again. My name is Baby Aya. So what I want to share with all of you guys. So I come into this work not only as an activist actually, but as a woman with live experience. Because I'm also using drugs and I live with HIV since 2002. And I'm work in harm reduction program in Indonesia since 2005, and keep trying keep trying pushing for decriminalization, for harm reduction and gender justice, even though we have to admit that harm reduction are very masculine, and me as a woman, and over there is my colleague, my best friend, Rosma Karina, that we think, because we start this I start first as a field worker of one harm reduction NGOs on 2005, and I work as a field worker for prison program. And sometimes we got very jealous with another harm reduction because I don't know, but in our country, in Indonesia, we have our law, our narcotic law are very punitive, and our Ministry of Health also seems like very dilemmatic with the harm reductions. They say we can do the needle exchange, but none with naloxone until now. We have the methadone, but non-overdoses prevention. So for us that live as a woman, that born as a woman, that acknowledge ourselves as a woman, we felt there's a diverse need that we have to shape on this, any kind of program, any kind of health services. So yeah, as a title of my this is actually a title of my abstract. We at Spin Foundation, actually, like I said before, we are a very new organization. We registered on 2022. We start first as a collective of women and trans women who using drugs on 2021, and it's only 6 person on that time. Even me and Rosma over there, we start working in harm reduction since 2005, 2006. But it took more than 2 decades for us can have, what can I call? Can have this, percaya diri, confidence to make our own organization as a women and gender diverse people who using drugs. Because also in our community, there's a very huge, even though in our community as a people who using drugs, there's not much acknowledged for women and gender diverse people who using drugs. That's why we start this on 2022. We launch our own shelter for women and trans women who using drugs that face gender-based violence, which is inside of the program we trying to we are trying to fill the gaps in the harm reduction program, especially on the sexual and reproductive health and rights, because as we know now, also in the globally very increased the numbers of women who use drugs and in the prison and also sentenced by the drug offenses. So in the closed setting, in our community itself, there's a very huge gap in the SRHR services. As a women and gender diverse people who using drugs, we are marginalized in our marginalized. So like if last time I attend this harm reduction conference on 2009, and until today, I speak again on behalf of women and gender diverse people who are using drugs, because we felt that even though in the harm reduction and HIV program itself is very masculine program, um, uh, uh, also in the narcotic laws. So we have to admit that many needs of our unique needs are not are not uh, are not met with the program. So that's why we are starting this project. Actually, yes, last year we are trying to build a partnership with the Indonesian Planned Parenthood Association, which is a member association of International Planned Parenthood Federation for Indonesia, and we are trying to make some very small, actually very small survey and also focus group discussion, because we need to know what exactly the needs of our communities, what it's the needs of their, what it's they want to address with their sexual and reproductive health, because in SPIN itself we have now almost 30 members that including trans women who are using drugs, that they have very limited information about harm reduction. They have very limited information about the hormonal therapy. They have they are also doing as a sex worker, and most of us are formerly incarcerated women. So we need to address this unique needs about our sexual and reproductive health. Among of us are also a mothers, are also a caregivers. So what we are trying to do, we build the partnership with the Indonesian Planned Parenthood Association, which is in our country is a very conservative organization that at before only do the SRHR in very conservative model. So what we are trying to do in the last year, we with support with the from IPPF, we make the survey and oh, no. Yes, what we are trying to do, we initiate the twin track strategy, what we are calling with the twin track. So there's a direct services and also for the system advocacy. So from our last year, only 3 months project actually, but from there we have yeah, we reach 99 participants, cis women and trans women who are using drugs, and conduct surveys and focus group discussion on sexual reproductive health and related services access. Because there is no like safe abortion services in our country, and explore the emergency shelter feasibility and give the mobile clinic services in community site, because we have to acknowledge it's not hidden. Women and gender diverse people is not hidden population. We are here. You can see us, you can hear us, but it's a very limited space that belongs to us. So what we are trying to do at SPIN we are creating those space that they can stay there in our shelter. They can just talk. They can just relaxing. They can bring their children also. Even though we are now also struggling with the core funding, we don't have any core funding. So what we are trying to do in our shelter are we build allies with many organizations, and we are trying to jump into feminist movement now, since 2 years ago and put all the intersectionality issues with the disability issues, with migrant worker issues, with human rights organization in our country, and sit together and talk about the drugs problem. And it's quite surprised because at the first time, the harm reduction program in Indonesia are very box to box to box. As you can see in the HIV program, it's very make us more outsider, more outsider. So me and our colleagues at SPIN, we through this survey. Yeah, you can see this. This is from our survey. Each of this number isn't just a statistic. Actually, it represents a woman who accessed care, who was treated with dignity, and who had her voice heard. So, from the 99 participants that we succeed to reach, we get more deep information about what are actually their needs despite of the harm reduction program, despite of the needle exchange at or naloxone or methadone, but they need to be heard. Actually, they need to be heard. They need to come to the health service provider, which can accept they as who they are. If I'm a woman, I'm a single mom, I live with HIV, I'm a drug user, I formerly incarcerated woman. I just want to access my health. I just want to access my rights. So that's what we are. The key insight of our 3 months project. Yeah, what we are learn. Shelter for most of us, I think, not only in Indonesia, I think, for mostly with women and gender diverse people, the shelter are very needs. Not the first need, but we are need our own space. We are need our own safe space. So because on that space we build our trust, we build our solidarity, we build our sisterhood. And what we are going to do the next after the 3 months, actually we thankfully after that 3 months, the IPPA and also IPPF, we got support for this year to another 1 year actually, but for the not for the core funding, but it's okay because we are the basic that we are thinking that the most need from our community is the education. So this 1 year on 2005 activity, we are encourage our communities, our friends, trying to educate them through social media, and we also made serial workshop for our community so people can learn who we are, or they can also share who they are in our shelter. It's a very safe place to share anything. And from there, we are trying to do to promote the gender responsive harm reduction reform. So because I know it's not a strategy. There is no strategy with the drug policy reform. Me and my colleague Rosma Ferde, we just say, as long as we're crazy as a human, and as long as you're still alive, then go for it. You need to speak. You need to speak what is your rights. You need to speak what is your needs. So that's what we are trying to do to encourage our communities, that you have the rights. You are human. You don't need to catch up your rights. It's on your body. It's already on your body. But we have also have to admit that many of our communities still lack of their rights. So Yes, yes, sustainability and call to action. Actually, we thought that this partnership between community-led and organization who running the SRHR program are works that we can build the partnership. Not only, but the community itself should be out loud. We should place our needs on the table. Yeah, we have to say also this happened to the donors. We can say what we are want. We can say what we don't want to do, to even though to the donors itself. So but if the consequences, if you're not getting any money of that, it's okay. Just run and run and run. So because this is not about, this is about rights. This is not about charity. So yes, this is our acknowledgement for International Planned Parenthood Federation through their member association in Indonesia. They're starting to see us as human. They're starting to see the SRHR is needed with all the human, not only women and gender diverse people who use drugs, also men. Also, for all of us, we need the SRHR, not only women and gender diverse people, actually. And so, yeah, for my conclusion for today, before we close, true change begins when we listen to the voices that have long been silenced. So what I'm trying to do for more than 2 decades, that I encourage all of my sisters to speak up. Please speak up what you are need. Please speak up who you are, what you are need. It's okay to be vulnerable. It's okay to be marginalized. It's okay to live with HIV. It's okay to be formerly incarcerated women. It's okay to use drugs. As long as you're human, as long as you have a heart to live with all the compassionate that you can give to yourself at the beginning, so you can give also to others. So that's all from me. Thank you.
Told ya. Told ya they were gonna just blow it out of the arena here. So questions, we're gonna, right? Questions, and Clayton, are there questions online? Okay, so.
Hi, everybody. So thank you, baby, for this presentation. My question, so I want to acknowledge that, you know, I'm a femme, non-binary person who uses drugs. So this is, you know, a breath of fresh air. And also made me think about a question I want to ask Jose, so I'm going to switch to Spanish. ¿Por qué tú crees que solamente, ¿verdad? Hay 3 mujeres que se atendieron en la clínica de Methadone, y qué ustedes creen que como programa pueden hacer para llegar a estas mujeres? I'm going to say it in English too. Why do you think that there was only 3 women being attended, given services in the clinic? And what do you plan on doing to kind of address that gap and give them services?
Bueno, para contestarte la pregunta, en Puerto Rico el consumo de drogas inyectables de mujeres es bajito, no es como que hay una población muy alta de consumo de sustancias en mujeres inyectables. Sí, las mujeres consumen mucho más opioides a nivel de orales, pastillas y todo lo demás. Otra situación también que puede ser, que suceda, que la hemos visto mucho también, es la dependencia de sus parejas en ocasiones. Y pues les impiden en muchas ocasiones salir a espacios donde se van a encontrar con muchas más personas por aquello de pues, pertenencia, el sentido de pertenencia, de que la mujer me pertenece, y no les dejan llegar a estos servicios. Pues ahora mismo se está trabajando, ¿verdad? El poder accesar a las personas. Tenemos un equipo, ahora hay más muchachas trabajando con nosotros, más mujeres, que son las que tienen, ¿verdad?, esa apertura, porque nosotros como figura masculina, el poder llegar a las mujeres, si la mujer tiene su pareja, se nos hace un poquito bien complicado por aquello de que podemos tener, ¿verdad?, ese roce de celos y de otras situaciones con la pareja de la persona. Pero ahora estamos trabajando, tenemos mujeres que están llegando a la calle, que están haciendo el alcance comunitario, el outreach, y pues se está trabajando de esa manera.
Hi, I'm Judith from the UK. I'm a retired GP, and I know Sue's work. Sue, it was very moving to see the slides and the images that you showed, and we were all shocked to see needle litter all over the floor like that, and people injecting and using in such unhygienic situations. Do you think the people that you're working with and the excellent work that you're doing would be willing to go inside if the UK government would allow a safe consumption place? So that sometimes, I know they don't like buildings always, they might go inside and use inside in a more hygienic situation. And why do you think the UK government is so slow to think that this is a good idea?
Well, I mean, this is something that I've talked to the guys about. It's funny because they will raise it with me. They will ask questions like, why don't we have places where we're allowed to go and inject like they do in other parts of the world? So they know that these places exist in other countries, and they will ask about it. They will also ask about, why can't we have injectable heroin? So they know about sort of things that are available, So I think undoubtedly they would use an overdose prevention centre if there was one there. I mean, in actual fact, in terms of what we do on the project, we will literally be somewhere where we're almost like right next to an outdoor injecting space, and people will maybe come see us arrive, because I operate from my car. So they will see me arrive, and they will come over. They will maybe get a cup of coffee, something to eat. They will then go off and buy their drugs. And before they use them, they will get their injecting equipment, and we'll have a talk about what they're doing. And then they go and use, and then they come back to us. So we're kind of, this is the ridiculousness of it. We're kind of there for all of that bit, apart from the actual bit where they're injecting, So it is definitely something that they would use, I would say. The other part of the question, in terms of, why doesn't the UK government, I know in Scotland, obviously, one has just recently opened, but in England, obviously, we're still in a situation where we haven't got any. Why? I can't answer it really, because to me, working in healthcare and as I've shown in the presentation, the amount of health issues that people are dealing with as a result of us not having a space, a more hygienic clinical space, or whatever you want to call it, a space where people can inject in a kind of safer way and a less harmful way. To me, it just makes health sense from a public health point of view. It's just, to me, it's just difficult to understand why we haven't taken that step.
One quick question. You provided, and thank you for all the work that you're doing on the ground. It's impressive and humbling to hear. You provided a quote that says, and I like the quote a great deal, "This isn't a pilot, it's a prototype for rights-based collaboration." Can you say a little bit more about how you think about that and where that quote comes from?
Yeah. Why I I see this like a prototype because there is none such an initiative like this since our first beginning harm reduction. So this like a prototype that everybody can use. Everybody around the world, from women and gender diverse people who using drugs, especially that common with Indonesian situation, that very punitive drug law, criminalization is everywhere. There is no acknowledgement for the gender diverse people. So we can try this prototype of kind of community-led initiative. At first, me and my partner over there also scared how if our own community do not want to recognize this kind of initiative, but as we built this collective, we built this organization based on our lived experience. That's our strength. That's why we can tell this is our needs. This is that's why you can also now actually the next now what we are going now is we develop our own guidelines for the SRHR approach for women and gender diverse people, but still ongoing. So this is a very new initiative from community that we are trying to make our own guidelines based on our lived experience. So, yes, thank you.
Questions, comments? Well, I am honored to have been a part of this panel as closing out this conference. It's just, you're all doing incredible, fantastic work, and wish we could clone you all. I actually had a question for you, to Tatyana. Are you a prescriber?
Yes, I'm a psychologist initially. I'm a clinical psychologist, but the only people who can prescribe opiate substitution treatment in Lebanon are psychiatrists, and not any psychiatrist. So it's a registered psychiatrist that has to go through an OST training program. So we don't have that many actually. And this is also a very big problem. We're trying to expand the network to have GPs be able to, as a first step, and then hopefully nurses. I mean, the reality is that nurses do all the work. But including the actual prescriptions, it's just, the oversight of the psychiatrist. I mean, they're the ones that are doing the follow-up. They are the ones that are actually talking to people and checking on them. But it's just a really top system where only a psychiatrist can do this. And this is also what limits the access because most psychiatrists are within the capital. And it really has to rely on the will of the psychiatrist to be wanting to get that training to be able to prescribe. So it's a whole process.
Well, on our prep call, I just need to repeat it for the benefit of others. If nurses could run healthcare, we would all be well. Right. Thank you all for attending. Thank you.